terms of thinking about antibody choices in relapsed refractory disease, I think what we have to recognize is that daratumumab is going to be increasingly used up front. And obviously patients will be on daratumumab maintenance. So when patients relapse, what will be the best CD38 to choose? Well, obviously retreatment with daratumumab is one very reasonable and an important strategy. However, Isatuximab, which is a chimeric antibody, so it's distinct in its structure from daratumumab, also targets CD38, but most importantly, it binds to a different epitope, and that leads to different properties. Essentially, the apoptotic pathway that Isatuximab targets appears to be more important for Isatuximab's mechanism of action than to the same extent that it is seen with daratumumab. And that important difference may explain actually some of the very exciting results that we've seen. Another point about Isatuximab is that it does not activate complement, so its infusion time is much shorter by the intravenous route, and very importantly at the same time you don't need a lot of pre-medication, and patients with asthma and COPD, or chronic obstructive pulmonary disease, can be safely treated with Isatuximab. So in our ICARIA study, we were able to demonstrate very nicely that in this frailer real-world population, and in fact we presented a very nice poster by my colleague, Dr. Frederick Schjesvold, who is originally from Norway, and Fred showed very nicely that the elderly population were able to tolerate the pomalidomide Isatuximab dexamethasone platform particularly well. In the broader scheme of this study, which again we presented both at ASCO and EHA, we were able to show that it was broadly very active. It doubled PFS, doubled response rate, and there was already a survival signal, not yet significant because the data are not mature, but there was clearly a trend in favor of the 3 drugs over the 2, with a very impressive hazard ratio. So with all of that in mind, what was very nice at the International Myeloma Workshop, which we held in Boston this year, a very nice presentation by Dr. Simon Harrison on the high-risk subgroup, demonstrated very nicely that in high-risk patients, the combination of isatuximab, pomalidomide, and dexamethasone was very active. And this, I think, is important. So it suggests that there's a real role for this antibody in the relapsed refractory space.